Welcome and thank you all for joining us today for the webinar, Supply Chain and Enterprise Risk Management, Navigating the Unknown, presented by the Association for Healthcare Resource and Materials Management and the American Society for Healthcare Risk Management. Hi everyone, this is Mike Schiller, Senior Director of Supply Chain at AHRMM, and I will be moderating today's webinar, which is the final webinar in AHRMM's CQO Thought Leader Discussion Series, Re-Engineering the Healthcare Supply Chain. These webinars are made possible by AHRMM's CQO movement sponsors, Vizient, Cook Medical, Health Trust, Premier, Nexera and Acuity, and Pampers. The AHRMM CQO movement frames the critical role supply chain professionals play in driving high-quality care at a more affordable cost to deliver greater value to patients. Some housekeeping items for today's call. All lines have been placed in a listen-only mode, but you can ask questions by typing them in the Q&A box. The Q&A box can be opened by hovering your mouse at the bottom of the WebEx browser, clicking the ellipses icon, the one with the 3 dots, and clicking Q&A. The Q&A will be held throughout today's session. And after the webinar, please be sure to complete the presentation evaluation so we can improve our education for you and other healthcare, supply chain, and risk management professionals. Registrants will receive their continuing education certificate about 2 weeks after completing the survey. We are pleased to welcome today's panelists, Barbara McCarthy and Mary Beth Briscoe, who will share their thoughts on COVID's impact and the risk factors associated with the healthcare supply chain. Barbara McCarthy is the Enterprise Risk Officer at Beverly Hospital and ASHRM's 2021 President-elect. And Mary Beth Briscoe is a former CFO, Healthcare Supply Chain Executive, and AHRMM Board Member. Thank you both for joining us today. Our goal is for today's webinar to be highly conversational between myself, our panelists, and you, the audience. Please participate in our 2 polling questions and feel free to share your thoughts and questions during our discussion topics. Our goal is to incorporate your polling response, thoughts, and questions into the context of our dialogue. That said, let's move into our first polling question. Prior to COVID, how did you rate your supply chain on a scale of risk? And Barbara and Mary Beth, while we're waiting for the polling question to be tallied, traditionally, senior leaders have been asked to list some of their top risks. What would have been your pre-COVID-19 list?
So thanks, Mike. You know, I think that risk managers are used to doing what we would call an environmental scan, taking both external factors and emerging risks as well as some of our internal data and doing that. And I would tell you that regulatory change is probably high on the list for healthcare in our space. Also, succession, talent planning, some of the things also privacy and cyber is high on that list, and also how we deal with digital technologies and new technologies. So it varies quite a bit.
Thanks, Barbara. Mary Beth, how about you as the CFO?
Sure.
What would some of your risks be?
Well, I would include everything that Barb just said, but I would also include the continued healthcare reform in terms of pressures from the government, from employers, and the continued pressures on reimbursement. And on top of that, I think what we have seen is what I will call disruptors, new entrants into the healthcare space that historically have not been there, that are really going to make us change how we do business. whether that is patient satisfaction, convenience, that sort of thing. And definitely agree with the technology, and particularly at this point, even telemedicine. While it's a really good thing, we also have to realize that there are also some risks related to telemedicine.
And I would add one more, Mike. I think that healthcare is still in the mode of mergers and acquisitions, and I think that also plays into some of the things that we'll be talking about today, but that healthcare is still a competitive sport, and we also need to recognize that as well, and that value-based purchasing and how we, as Mary Beth said, buy healthcare and pay for it plays into what we'll be talking about as well.
Excellent points. Excellent points. So we've got the polling results here. And prior to COVID, looks like the bulk of organizations rated their supply chain as a medium risk. That was followed by low risk, and then a few, small portion, listed it as a high risk. So, the points that you've made as far as pre-COVID risks, those no doubt are still valid today. But let me ask this part, the second part to the question. What would your top risks look like now? How has it changed pre-COVID to today?
I think that certainly all the things that we talked about still stay on that list. But I also think that what we've seen, and I'm going to share one thing that I think is different from pre and post, is that there was always a sort of a resistance to change on the part of healthcare, that we were always seen as not as innovative or creative as we could be. And I think that what this has done is change that mindset. I think people have had to change how they take care of patients, how they do business, how they use their PPE, what supplies they use on a dime. And I think that unfreezing that resistance will provide us with an opportunity. So I think that has changed somewhat, and I certainly think that disaster planning, emergency management, and supply chain have moved up in that slot of top 5 risks.
Right. So, Barb, I totally agree with that. And I, too, would say nothing comes off the list that we talked about pre. I think we just add some items that may have been lower on some of our lists that have now really been heightened. And I heard somebody make a comment back some time ago that COVID has elevated the supply chain from the basement to the boardroom. And I do believe that has absolutely occurred. And this is a great opportunity for supply chain professionals, risk management people to elevate this and continue with that spotlight on that particular resource. Also, remote workforce, with all of our workers, or many of our workers, moving home and working from home, that's going to continue to enforce our cybersecurity risks and things like that. So I think definitely supply chain, the cybersecurity risk would all have been elevated in my mind. And, we talked a lot about, we as an industry, we've been talking about telemedicine. It is something that we had really wanted to push forward, I think, as an industry, but maybe we had not made as many strides as what we had hoped. And then I think, again, one of the positive things that has come out of this is that many organizations really sort of flipped on a dime over a period of weeks, of course, but, and implemented many telemedicine alternatives that previously they were not able to sort of push through. I mean, again, what Barbara said, change was not something that was maybe readily adaptable in many of our organizations. And so, and the other thing that I think I would just add to a risk, and that is not only the ability to recruit and retain our human capital, but to be sure that they are safe and many of our workers are burned out. And maybe in the past, we had talked a lot about clinicians and clinical burnout. And I think now we're hearing a lot more people talk about the holistic part of the organization, our supply chain staff. It's not just the clinicians, it's everyone. So I think that this has put a lot of pressure on our manpower and our staff and the whole. And so I think that that would definitely be something that we would have more of an eye on now.
Yeah, those are all great points. Absolutely. It's interesting. There's a survey that came out back, I think it was April or May. And of course, right at in the heart of COVID, but it was a survey of senior leaders in the hospital setting. And of the 6 questions that they asked, again, more COVID focused, the points that you're making about the workforce, right? Not moving beyond what we had called in the past the quadruple aim. We're still calling it that, actually, but where you're focused on clinician and physician burnout. You're absolutely right, Mary Beth. Right? It's now more the entire healthcare workforce, and so that was a top concern of executives. And the supply chain, in all 6 questions that they had asked the senior leaders, supply chain was in the top 5. So again, the importance, I think, on both of those factors, in addition to the other points that you both have made. I think change management is probably one of the biggest hurdles that we have to clear. And, we'll get into that just a little bit later on in our conversation today. But that remains, in my mind, probably one of the highest hurdles to clear in any organizational setting. Would you agree?
Yeah, I would agree. I also think that, Mike, some of our discussions you and I have had is that, the supply chain has always been of the first place for cost containment, and I think that folks saw it as a place that you didn't impact FTEs within an organization, but could save some money and some dollars, and folks were incentivized. We all were to make those changes, and I think you'll see a softening of that stance and that approach as we begin into some of our action planning.
Yeah. Well, and I would add too, I think that not only maybe the rate of change, but I think the breadth of change that organizations and people that I talk with, it's coming from every direction. And organizations really having to prioritize many different needs for change all at the same time, because as we're saying, there's only so much that an organization can really take on at one time.
Yeah, and there are so many competing priorities today, and you're absolutely right. You run into a bandwidth issue. You talked a little bit, Mary Beth, on some of the pre-COVID risks, and the move to a value-based care environment. Right. is a huge challenge, because it's not like you can add an additional workforce to focus on how to move the organization to value-based care while still maintaining some of your day-to-day operations. It's all reliant on that same staff. They've got to keep day-to-day operations, but they have to move the organization to be prepared and ready to operate within a value-based care environment, which is incredibly challenging.
Right.
Very good. Well, this is great dialogue. Again, I want to go ahead and invite the audience, please, if you've got some thoughts or want to participate in the conversation, go ahead and enter your questions or comments into the Q&A box on the WebEx platform. We'd love to incorporate those into the conversation. So let's move into our second polling question here. We would love to know what % of your supply chain is manufactured outside of the country, outside of the U.S. And Barbara and Mary Beth, anecdotally, let me frame this up a little bit. Right now, approximately 90% of the PPE that we're using is manufactured outside of the U.S. That's a significant number, and something that, of course, there's been a lot of discussion about changing that percentage, right? API, active pharmaceutical ingredients, as of August of last year, just a year ago, numbers were in the range of about 70% of active pharmaceutical ingredients were being manufactured outside of the U.S. And I've heard numbers this year as high as 80% of APIs being manufactured outside the U.S. So certainly when we talk about risk to the healthcare supply chain, those are two huge risk factors. And it'll be interesting to see how our polling responses come back regarding the entire supply chain, what that percentage looks like. But thoughts that you guys have regarding this risk?
Well, I think the first thing we have to talk about is what's the definition of supply chain? And I think that it could be the supplies that are stored in your warehouse. It can be your pharmaceuticals, but then you also have all the equipment that runs your facility, whether it be clinical or non-clinical equipment. You have your IT supplies. You have your food source. So if you look at supply chain with capital letters, and then you apply this question, those numbers are going to change. And I think that, in my thinking about this, there's not a good place to talk about supply chain with capital letters because everybody really has their swim lane that they're very good at. And that may impact how you answer this question and how you think about it as a risk to the organization. When if you packaged it together, it might look very different to present to top leadership.
I would agree with that. I think for maybe the way that this question, to your point, Barbara, you're going to get different answers. And across the industry, I don't necessarily think that everybody defines supply chain the same way, right? In some organizations, it's your historical, these are the supply chain functions, logistics, warehousing, all that sort of things. In others, it has broadened in its oversight and integration in the organization. In others, it's sort of defined as anything that, there's two buckets. There's labor costs and then there's non-labor costs, right? So I think to your point, it's going to differ. The interesting thing about this question, though, to me also is and I'll just say personally, if you would have asked me this question either several years ago or whatever, I don't think that my mind at that point thought through where the items were coming from. I think, Barbara, you said it even earlier about supply chain has historically been viewed as we want to get the product in and we want it at the best price, right? The focus was maybe historically, and I'm interested in y'all's comments about this, was historically about the price. And then we began to attach the price with the outcome, right? I don't know that we, as holistically looked at where things were coming from and looked at our risk related to that. And of course, we're developing and growing out of some of that. But I'd be interested in your thoughts about just historically how you think that it's been viewed.
Oh, you're absolutely spot on. That's been the key focus of supply chain professionals, right? Is price. At the end of the day, $1 million in supply cost savings goes immediately to the bottom line. There's some figure out there, and I might be getting these numbers wrong, but you would need $1 million in a revenue generating program to add $100,000 to the bottom line of an organization, but you can take $1 million out of your supply cost, and that's immediately dollar for dollar. It's the bottom line. So yes, cost has always been, the primary focus, and that's really what CQO is all about, right? Yeah. Cost will always remain an important variable, but now it must be considered in relationship to the patient experience, the patient outcomes, the performance of the product, as well as in a value-based care environment, what that reimbursement looks like through improved patient care. So, and I think that's, again, going back to kind of the change management model, and Barbara, what you said, I think that's a hurdle that needs to be cleared. I think we're getting there, but certainly a concern of mine coming out of the COVID situation is that we're going to jump back into the price-only mode, and I think there's opportunities to look for other areas to drive savings. And I know we're going to get into that in just a moment, so I don't want to jump too far ahead of the conversation. I do have a question here I'd like to bring to the group. How do you think low unit of measure with distribution partners will or should change post-COVID? I definitely have some thoughts, but Barbara, Mary Beth, do you guys have any thoughts on how it should change or how it will change?
I'm sorry, I didn't catch all of your question, Mike. I apologize.
Sure. No. How do you think low unit of measure with distribution partners will or should change post-COVID?
I'm gonna defer on that as a risk manager.
Yeah.
Because I think it's something that when we talk about the collaboration between the two services, it's probably something that risk managers need to know more about.
Mm-hmm. So, Mike, why don't you take that one, and then I'll respond. I want to see if we agree.
Okay. I'm pretty confident we will, but I can tell you that, just in time has been a principle that's been employed in the healthcare supply chain for a long time. And it not only applies to the supplies within the four walls of the hospital, that methodology has moved upstream into the distributor setting as well as to the manufacturing setting. And what that's created is a fragile healthcare supply chain that does not have the ability to flex tremendously, right? You got a little bit of flex there, but you don't have the flex that's needed in an environment like we find ourselves today, which is one of the reasons why we're where we are as far as product. You also have a global demand now for a PPE product, which puts additional strain. But I think that you're going to see just-in-time principles and management be loosened up a bit. Let's say moving from 3 days of inventory on hand in the hospital to perhaps 7 days. But I think that mentality needs to move upstream into the distributor and the manufacturing setting as well. And we'll get into this on the last topic we're going to talk about, where we're going to need data analytics to really help us understand utilization and transparency. But I think the days of a true JIT inventory, we might be seeing the end of that, and it might be a JIT plus.
So I agree with you. And the other thing, a complicating factor for some organizations is that when facilities were built, right, there's not enough space in the facility to hold more inventory. So then you have to go outside elsewhere, increasing, warehouse costs, things like that. And we're going to talk about this in a few minutes, but it's going to be changing our historic processes, which in many instances may increase our costs. I hate to say that again, but we have to face the reality. And I don't know, there's two types of costs. I don't know what organizations, they're either going to have to go out and get more warehouse space. That's an area for collaboration. Or they're going to have to find space within the facility to accommodate that. But again, we can talk a little bit more, but really I think the main thing is being able to tell and articulate to your organizations that there becomes, if you want less risk in some things, then we're going to have to find ways to do that. And sometimes it may cost us money. So just being able to articulate the level of risk, and then what's the level of investment, be it either in terms of money, people, technology, just so that everybody does now, coming out of COVID, understand where we're starting from within the organization.
And that's a great point, Mary Beth, and we actually talked about that on our last webinar series, where we need to make sure that the conversation doesn't focus only on cost, right? Cost of systems or infrastructure to manage inventory, but we need to make sure we're talking about the value that it brings. And without a doubt, if we're looking to bring more manufacturing into the U.S., we're looking to diversify our vendor portfolio. So that we've got multiple vendors, multi-source contracts, moving away from single-source contracts. The potential that the product supply cost, that line item in our budgets, will go up. But there's ample opportunity in other areas that we can go ahead and offset those potential increased costs with savings. And so one area is a term that I'm hearing more and more out there is this shared economy concept. So we can touch more on that in just a moment. So let me cover the survey results here as far as the percentage of supply chain that is manufactured outside of the country. Majority of the folks have 50 to 74%. That's significant, right, when we begin to think of a risk to an organization. That's followed closely by 75 to 100% of the supply chain being manufactured outside the U.S. And then we've got a few respondents that are 25 to 49%, and then just a handful that are less than 25%. So definitely a key risk factor. So Melissa, Shane, if we can go ahead and put up our AHRMM model, I'd like to spend a little bit of time talking. We're definitely not going to go and cover every single topic. We just don't have time to do that. This could be a 6-hour webinar, and we don't want that. But Barbara, if we could kick it off with you, if you could just speak to one or two of these items on here. And then Mary Beth, same with you. And then I'll kind of wrap it up with some thoughts I have regarding this AHRMM framework.
Sure. Thanks, Mike. So this is a framework that we use in risk management fairly frequently. And what it does is it sort of lays out in a grid format everything that might go wrong, could go wrong, or might be a risk. What I think it does do is it also allows you to see where there are similarities across some of these domains. I think that we go into risk, we go into any sort of thing that we're doing with, we think we know the answer. And so we go in with the end in mind. What this forces you to do is step back, put it on a whiteboard, put it on a piece of paper, and look at it in total to see how they compare and contrast across all of these domains and how you see how one is always linked to another. So I'm going to talk a little bit about operations and some about patient safety, which bleeds into human capital as well. So if we talk about the operations piece, I think I've already talked to you about my sort of thoughts about the fact that we have a variable definition of what supply chain is. We've also just talked about just-in-time management and the fact that once that product leaves the warehouse or leaves the storeroom, how do we keep in touch with that? How do we make sure we know what par levels are, what outdates are, and those sorts of things? So it really is a sort of spider web to make sure that the operational piece of knowing where every product is at any point in time is understood up and down the supply chain. I think we're doing much better on vendor assessment and performance. A lot of us have electronic ways of helping to do that, as well as outdate management and a little bit on recalls and hazard alerts as well. So if you move over to the patient safety side, we have talked somewhat about evidence-based protocols. I think we need to speak to get a little bit on the action planning side. Most of us have some sort of process for value analysis or getting some sort of clinical acceptance model going, but I do think that's a risk. I think that if you were to pre-COVID ask a lot of surgeons or physicians or individual specialty departments and services what products they have to have, in quotes, to be able to run their department, it might look a little bit restrictive than maybe what it looks now. I think that relaxing of what we would consider an acceptable substitute, what we would consider clinically acceptable, what we would consider evidence-based and okay to use is probably better today than it was in January or last year. I also think that we do absolutely have to pay attention to employee engagement. And I think we have employees' attention right now that products are a big deal, that they need to get involved, that they have an opinion, that they should help us with trials, that they should give us feedback on supplies, and that only makes a stronger supply chain overall, and we need to capitalize on that. And lack of clinical integration. We talked a little bit about mergers and acquisitions, and I think that, in our place we call it systemness. And systemness has its advantages, it has its risks, but its advantages is that we can put the product in the right place at the right time, that we can help with that sourcing and that pricing because we're big enough to be able to have some leverage in those discussions. But that systemness also allows us to evaluate clinical quality in a different manner than we probably have before.
So, Barbara, I really agree with everything you said, and I just want to take just 1 second because as we were preparing for this call and we started distributing, Barbara distributed this framework here, and I think that this is a very well done roadmap for many of us as we think about risk and think about it in a different way. I think it also, just this entire framework also illuminates where areas of collaboration exist between, when you're thinking about value analysis and risk managers, and really, and we're going to talk about this in a minute, is how can we collaborate even closer together? I think something like this just begins to point us in different directions of how we can work closer together. That way, it's not necessarily seen as the voice of one, when you're trying to make a point or drive an initiative. You have a partner that's sitting there and saying, yes, this is an issue that we need to think about. So very briefly, just a couple of thoughts about the financial impacts of all of what we've talked about. We've already discussed, if we change our just-in-time, we change, the way that we're single sourcing, things like that. All of that is going to need to be evaluated in terms of cost as well as quality outcomes and as well as de-escalation of risk, okay? So where most of the providers are right now, or many of them, they have had to pay higher prices for PPE. They have had to slow down elective volumes. And so now what we have is an industry that has got a lot of pressure on revenue, cost, and also a lot of need to manage cash. So really, all of those are areas of risk. And then again, as we're trying to de-risk some of the products, if we've got more inventory on site, warehousing costs, that sort of thing, really just approaching it from a holistic view and acknowledging if there is an increase in cost where we can actually decrease elsewhere. The other thing that I'd just like to take a moment, and it's over on the strategic and reputational column. I think that supply chain has had a wonderful and does have an ongoing wonderful opportunity. We've been in the limelight, and just being sure that we stay there. And so when you think about how interrelated all of us are, not only at this point, there's not necessarily a global approach to supply chain resiliency. And nationally, there are many different groups that have convened that are addressing different pieces and parts of the supply chain. But at the present time, I don't necessarily see, and I'm interested in comments from Mike and Barbara, I don't necessarily see the holistic view of all the pieces and parts of supply chain being addressed or fixed, if you will. You know, we can all do a great job within our own four walls of making sure that our supply chains are as efficient, they consider the risks involved, et cetera. But once you start leaving your four walls, then you're automatically reliant on other organizations, vendors, manufacturers, suppliers. And so I'm interested in, you know, on an ongoing basis, you know, we've got many people who are banding together, and our voices are being heard. They're being heard louder, you know, because there's more of us. But I still think we need to continue to build a cohesive, single voice for supply chain issues, not just now, but to address those on an ongoing basis. So, I mean, Mike or Barb, do y'all agree with that?
Yeah, I do, Mary Beth, and we're going to get into the next question coming up here. I think we can certainly dig into that a lot more, but just going down that entire column, you know, the lack of a global approach to supply chain, the national stockpile, strategic stockpile, pre-COVID and coming out of COVID, right? Or, well, we're not coming out of it, but you know what I mean, as we look to what do we need to do, right? And the lack of a national approach to supply chain. I think these are all key factors that we definitely want to touch on when we get to that next question.
Yeah.
As we wrap this up. So, you know, some of the comments, you know, a lot of the folks are aligned with the conversation and the points that are being made today during the course of this webinar, which is great to see. So a lot of alignment here across the attendees and the panelists. So what I want to talk about really is I'm just going to focus quickly on the technology, and I'm going to look at the first two there, right? The unique ID, the UDI, is not universally adapted. It's really not being adapted, implemented on the hospital side as rapidly as we'd like to see it. And the suboptimal data analytics, that's the direct result of the lack or the slow adoption rate of the UDI. You know, now, I know we talked earlier in the conversation today just about the number of competing priorities that healthcare organizations have, and we absolutely get that. But if we think about the value, the benefit that the UDI and data standards can bring to the healthcare supply chain, and when I say healthcare supply chain in this context, I'm talking about from point of manufacture to point of consumption downstream into the registries, right? It gives us increased transparency because we're calling the product by the same name across the scope of that supply chain, right? So now we have increased transparency, not only where product resides through the UDI and global location information that we have within the four walls of our system, but we have that visibility at the manufacturing level, the distribution level, et cetera, right? Transparency is key, and that's one of the things that keeps coming up in conversations that I'm having is the lack of transparency that we have. Let's face it, our supply chain is built on forecasting. It's built on purchase order history. It's built on some, you know, gut feelings. I know seasonally we need to adjust our inventory on these items a little bit higher. At this point in time, it could be a little bit lower. So there's not a real true analytics platform to really guide our decision making. And again, with data standards, with the UDI, that really empowers our data analytics and gives us the ability to have some really robust information to help guide our thinking and our strategic planning. Utilization, right? The big term, big buzzword during COVID has been, what's your burn rate? And so understanding what our utilization is, again, because we're calling that product by the same number up and down the supply chain. So understanding that utilization is huge. when we think about all of the emergency use authorizations that the FDA has issued, and I want to say the number is north of 160 now at this point in time, to get product into the frontline healthcare workers, to care for the patients, to protect the workers, right? So we've got a lot of non-FDA approved product here in the U.S. There's a significant concern about potential for recalls on that product. And if we're not scanning a barcode at the point of receipt, how do we know what we have in our system? And how do we know if we're affected by a recall on some of these products that have been shipped into the U.S. healthcare supply chain under an EUA? There's also the real concern of counterfeit product now entering the U.S. healthcare supply chain. I've heard stories where hospitals have purchased masks that did not meet the quality standards or the particulate filtration levels that they were supposed to meet. And so real concerns around that. So, that lack of visibility, that lack of validation, confirmation that the product is not counterfeit, et cetera. A lot of these can be corrected with a more holistic approach and adoption to the UDI and to data standards across the healthcare space. So I think that that's really important. So with that said, let's move into, bear with me, I just wanted to say, it looks like there was a question that came through. Actually, it's a comment. You would need to include infrequent events into your supply chain forecasting models that would also need to include manufacturing, inventory, and capacity. And that's absolutely right. And that's where that transparency becomes so important. We really do need to improve that transparency across the supply chain. Let's, with the time remaining here, let's jump into the third question. And this really begins to focus on where should supply chain professionals and their counterparts, the risk management professionals, begin to reduce and eliminate risk. Right? What are we going to do rather than slip back into our old comfort zones post-COVID, right? And I want to call this sustaining the pain, right? Or sustain the pain, which on our AHRMM framework here is under operations and hazards, right? Hard to sustain the pain and hardwire lessons learned so long-term changes are made. And evidence of this, let me just frame this up real quickly, and these will be some documents that we'll make available to the audience as well post-webinar. There was a report that came out back in 2014, another report on personal protective equipment, lessons learned from recent public health emergencies that came out in November of 2017. And I'll tell you what, if you read these reports, you would think they were written 2 weeks ago, right? Strategies for improvement include identifying where N95 should be used, right? In what environment? And in a high-risk environment where the virus can be aerosolized, right? We're talking about product availability to meet increased surge demand, right? And that requires analytics. These reports are talking about these things that we need. The need to centralize inventory, right? PPE inventory. And we have seen a lot of that, and that has been very successful in conservation efforts. A shared economy, right? Sharing supplies. The AHA has released the Dynamic Ventilator Reserve. Resolink has a bit of a shared economy where you can share equipment and supplies. Improve domestic manufacturing surge capacity. So these are all items that have come out of these two reports from 3 and 6 years ago, yet I don't know how much progress we've made since these reports were released. So how do we sustain the pain? How do we hardwire those lessons learned so that we don't slip into that comfortable old shoe when this pandemic subsides and we think, oh, here's some calm, and we've got another pandemic on the horizon, because it will happen again. So what I'd really like to invite the audience to do is to share what you have done or what you're beginning to do, or where you're starting to begin to hardwire some of these lessons learned as we come out of certainly the March, April, May timeframe with COVID, as we enter into these hot spots periods right now, and of course the unknown coming into the fall season when it's COVID plus, COVID plus influenza, COVID plus whatever else that might be, and the demands that will put on our supply chain, and again, the very limited PPE resources that we have. So with that said, Barbara, let me turn it over to you, and then Mary Beth, if you can follow up again with, what are some things that attendees can do to develop an action plan? And again, audience, please continue to fill out the Q&A in the chat on some things that you are doing or considering doing or have already done.
So thanks, Mike. I think that we need to get back to a mutual understanding. I think that risk managers are notoriously not strong in business skills. They're great at clinical skills for the most part, but not at business skills. And I think that needs to be an opportunity. And as ASHRM, we are focusing on that last year and also the upcoming year. I think that there's not a widespread knowledge between operations, risk management, and certainly operations and risk management about all the components upstream and downstream of the supply chain. I think we all see our small part of that, but to know the nitty-gritty of what happens, I just read a great article today about what it's going to take to manufacture a vaccine. The stopper is not made the same place, as we still are running out of sand to make the glass vials, and we can't do them in plastic, and this one and that one and this one. And so just to get a vaccine, just to get a test kit, to get something on the table, I don't think that's universal knowledge. And so that would be extremely helpful. I think that utilizing this sort of a framework and having that be a standardized way of doing business when we think about supply chain would be a step in the right direction. I also think risk managers are pretty good at risk management principles and treatment. How do you deal with redundancy? How do you deal with simplification? How do you deal with ways to make sure things are scalable so we don't have things that are on the shelf and outdate before we can ever use them? So I think that there's lessons learned from all three sort of parts of that stool, which is operations, supply chain, and the risk quality departments. So I'll kind of leave it from there. I do have one anecdote, is that, I have one brother who works in the semiconductor industry and is supply chain globally. I have another brother who is an enterprise risk manager for a place that does manufacturing with defense contracts. So you can imagine that, birthday parties are a riot, but we do talk about stuff like this, and how Chinese New Year has always impacted the semiconductor industry, and they plan around that, and how they think about resiliency as a defense contractor a little bit different than we might. So some of the things that we're talking about now, we should be partnering with other industries and our community partners, because we probably can learn a lot from them as well as from each other. So I'm going to kind of leave it at that. Thanks, Mike.
Thanks, Barbara. Mary Beth, any thoughts? And then I want to move to some of the questions here that our audience has posed as well.
Okay. So let me, and thanks, Barb, great answers. I think I want to start with the term leadership. I think it's very clear, particularly for people on the call today, and much of the discussion that we've already had, is this is a time where people will be listening, and you are in an enviable position to take leadership of addressing some of these issues and, if you will, at least developing a plan. So I guess my first thing would be make it real. Make it your own, but what is actually in writing and is endorsed actually becomes part of the fabric, if you will, of the organization. And so taking the framework that's here, and as well as the other couple of articles, I think that you're going to receive, you can make a plan for your organization, and make that plan be something that is it has many stakeholders as within that plan. Include supply chain, include the risk managers, include value analysis, whoever the appropriate people are, because then you can take it to senior leadership, can articulate these are the risks, get agreement on, yes, these are our internal risks, because again, we've got internal, we've got external, and what can we address just within our own institution, then outside of the organization, who do we need to be collaborating with? And then, of course, organizations like the two that are on the call today, as well as working with others in the federal government, that's where we're going to have to get out into the real industry, into a bigger size of the market. So I think it's at least a two-pronged approach, and there's a lot of tactics here that I think are very, very helpful. It's actually just taking a hold of it and, either adding to what you've already developed or use this as the beginning tool.
Thank you, Mary Beth. Yeah, I think we've had some comments here around this AHRMM framework that's up on the screen, and I think this is a fabulous tool. Barbara, when you and I started, you were listing off some of these key areas, right? And then, the three of us just started brainstorming and populating this. So it's not like this is a static framework that we downloaded from the web. This framework can be used at an organization to populate yourself. And I think that this framework here is the perfect point for collaboration to begin between supply chain professionals and risk management professionals within the organization. I think there's tremendous opportunity for both disciplines to cross-educate one another, right? To your point, Barbara, right? Bringing a little bit more of that business perspective that supply chain has and sharing that with the risk management professional. And of course, the risk management professional sharing their concerns and the need for redundancies in some area, which, we know that are being talked about. We're talking about multi-source contracts. We're talking about diversifying our vendor portfolios. We're talking about collaborating with local manufacturers in order to bring PPE. We've seen that happen during the heat of COVID, again, March, April, May months. And so I think this framework here is the absolute starting point. If you're not already working, this is I'm putting on my supply chain hat now, gang. If you're not already working with your risk management team in the hospital, this is your framework right here to begin those conversations and really begin to strengthen that relationship so that you can intentionally work together to address what will no doubt be some monumental changes to the healthcare supply chain over the next couple of years. So we've got just a few minutes left. I want to get to a couple of the questions that we can. And for the audience, please continue to post your questions in the chat or the Q&A box. We're compiling those, and what we don't get to today, we will ask our panelists to go ahead and complete so that we can get those out to you post-webinar. But do you recommend conducting a failure modes effect analysis for the supply chain? Please explain.
I can take that one on. You know what? Absolutely. I think that, so a failure modes and effects analysis is essentially, as this is a framework for enterprise risk sort of view, an FMEA is a risk assessment that you can, that allows you to prioritize and to identify some of the top things that you could work on. And it is a perfect framework to use for supply chain. Absolutely. That is a great suggestion. And we could do another webinar just on an FMEA for supply chain. Absolutely.
Yeah. Might not be a bad idea, Barbara.
That's right.
We can shoehorn it into your busy schedule.
There we go.
Mary Beth, any thoughts?
No, I think that I totally agree. I think any opportunity that we've got, I think it's wonderful.
Yep, I absolutely agree. Again, another great point and opportunity for these two disciplines to work more closely together if they're not already doing so. I'm going to answer one of the questions here that's come up. A lack of storage space available for increased inventory is a significant risk. how are your organizations assessing this exposure, and what solutions can you offer? So, I'm going to go ahead and I'm going to kick this off, and then, Barbara, Mary Beth, would welcome your thoughts. What we're seeing is there are organizations that either have space already that was unused and they're building it out. In conversations I've had, we're seeing other organizations go out and rent or lease available space just for that need to increase their surge inventory levels. A lot of hospitals now, because we've kind of flattened the curve, I would say, from a national peak, and now we've got the hot spots. But hospitals are in a let's build a surge inventory mode as we into this build the surge inventory mode or mentality as we get ready to move into the fall months. So that's one area what we're seeing folks do, right, is lease or rent some space for that. There's also, I had mentioned a little bit earlier, the shared economy mindset. And I know that there are some hospitals either at a regional level, local, regional, or state level that are beginning to look at, as opposed to 5,500 hospitals all running out and building their own surge inventory, how can you do this as a coalition, right? And so maybe somebody's got a consolidated service center that you can utilize for this shared inventory across these healthcare systems, again, local, regional, or state level. So those are some of the thinking and some of the activity that I'm hearing and seeing out there as I talk to my colleagues. Mary Beth, Barbara, any thoughts or comments you'd like to add?
Yeah, could I add a caution? I think the caution is that we would never have been able to forecast the amount of PPE we used and are continuing to use for our COVID response. And so I caution that when we use our forecasting and we get back into sort of doing an FMEA and looking at these frameworks and putting our value analysis committees back together again to be able to plan for that next big, huge event, we have to caution ourselves that would be way too expensive. And how do we manage that realistically and with responsibility and not use what we've used for supplies over the last 3 months as our baseline, because that's going to be unsustainable in the future. So that's my only caution in some of this as well. And I don't know how you handle that, but there is a balance there somewhere.
Conservation is absolutely a key initiative here, and we're going to have a sustained period here where demand will continue to outstrip supply. I mean, you had the perfect storm set up. You've got 90% of manufacturing outside of the U.S. You had a decline in manufacturing capacity and exports because the virus hit in China. At the same time, you've got a global demand for that very same product. Now we've got an environment where production and exports are starting to move up, but you've also increased the number of participants dipping into that PPE pool. You've got employers who are looking to buy PPE for their workforce. You've got schools who need PPE. You've got other businesses. You've got these other players now that in the past have not had a need to purchase PPE who are. So while we're seeing that uptick in manufacturing capacity and exports, we're also seeing more players enter the market for that same supply. So this is something that's going to be ongoing, and conservation is key in allowing us to be able to adapt and remain flexible coming into the fall months.
Can I plug a book for a minute, Mike?
Yeah,
I'm going to plug a book for this
group. Then we got to wrap up.
Yep, and the book is called The Gray Rhino. We've heard of the black swan, we've heard of the elephant in the room, but read the book called The Gray Rhino by Wucker, W-U-C-K-E-R. It's exactly supply chain and how we can go about thinking about problems such as this.
That's great. We will we'll put that out as a resource here after the webinar. So I can continue talking with you guys, the audience. You guys have been fabulous with chiming in with your comments, your thoughts, your questions. Thank you. This is exactly what I was hoping it would be. Unfortunately, we are out of time. So Barbara, Mary Beth, thank you guys again for your time today and providing us with thought-provoking information and, of course, the action planning ideas that we've discussed. We really appreciate you taking time out of your schedules today to speak with us and our audience. We also want to thank our CQO movement sponsors for making today's webinar possible: Vizient, Cook Medical, Health Trust, Premier, Nexera and Acurity, and Pampers. Again, if your questions weren't answered today, please keep them coming in. We're going to compile them and we'll ask our panelists to respond to those. Please let us know what you think of today's presentation by completing the survey, which will pop up as an external site at the conclusion of today's webinar. AHRMM members will receive the evaluation for AHRMM credits on August 14th. For more education focusing on healthcare, supply chain, and risk management, please visit AHRMM.org and ASHRM, ASHRM.org. Again, thank you all for joining us and your continued hard work during these challenging times. We look forward to seeing you at our upcoming AHRMM 20+ virtual conference, which kicks off on Tuesday, September 22nd. Until then, stay safe, stay well, everyone. Bye-bye.
Thanks, everybody.
Thanks.